All right, everyone, it is now 11:15. We're going to go ahead and get our next session started. Good morning and welcome everyone to the 2024 PI Conference and our 11:15 session, Overview of CGD. My name is Emma Mertens, Program Manager of Community Health at the Immune Deficiency Foundation, and I will be your moderator for this session. Thank you to Amgen for supporting this session. This session is 45 minutes in length, and if time permits, our presenter will be happy to address a handful of attendee questions after his talk. Please note that the information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Here at IDF, we offer a wide array of educational presentations, including those developed by healthcare professionals and lifestyle management professionals, who we have invited to serve as presenters. The views and opinions expressed by these presenters do not necessarily reflect the views and opinions of IDF. But without further ado, I am so pleased to introduce our presenter for this session, Dr. Sergio Rosenzweig. Dr. Rosenzweig is a pediatrician and clinical immunologist with over 25 years of experience in the field of primary immunodeficiency. Dr. Rosenzweig is an NIH tenured senior investigator and chief of the Immunology Service, Department of Laboratory Medicine at the NIH Clinical Center. For full presenter bios, please visit your conference app. Thank you, and please join me in welcoming Dr. Rosenzweig.
So, thank you very much, Emma, for the kind introduction that I wrote for you. And I want to thank Jory Berry for organizing this, Catherine Lomtalk. I want to also thank Kate Sullivan and Ramsey Fulaham of the Medical Advisory Committee for inviting me here. And I especially want to thank you for being here. This is a very interesting experience for us, and you are teaching us a lot. So let me try to retribute something to you. And I'm going to give an overview of CGD. I know that you are perhaps even more experienced than I in terms of CGD. I work in CGD for more than 15 years, but you are pretty well versed in what I'm going to talk to you and what I'm going to tell you about. So if I make any mistake, please don't throw them in my face. So just take me aside and tell me that I was getting something wrong, but I will try to get the data straight. And it's going to be overview. So it's going to be not in depth, but then at the time of the questions, we can go in depth for whatever you want, and you can test how much I know about CGD, like this. But that's fine. So we're going to cover different aspects of CGD. So we're going to talk about the history, pathophysiology, clinical manifestations, genetics, and diagnosis, and we'll put more emphasis on those two aspects because those are the ones that I was asked to speak more in depth. Treatment as prophylaxis, as curative, but nothing going to be as in-depth as the genetics and the diagnostic aspects of CGD that I know that you're experts on. So let's start about the history. So this year, it has been 7 years that CGD was first described. So the whole journey about having a disease with its name and going to gene therapy, it has 7 years. I know that sounds like a lot of time, but 71 years ago, this disease has not been acknowledged, and has not been described, has not been recognized as this. So the first one was in '54, and it was kind of a syndrome, hypergammaglobulinemia, severe recurrent infections, non-specific infections, not very specific, not very thorough, not very detailed kind of name of disease. And then the infamous name, fatal granulomatous disease. Fortunately, we moved away from that. That was back in '59. That was Robert Bridges and our good Robert Good that they described this disease, but that's kind of the cornerstone of CGD disease. They started with this ugly, nasty name, but then we moved to chronic granulomatous disease. That is how we know it now. So, but what it is CGD? And I know that you know, but let me kind of remind you what it is CGD. So the whole problem about CGD is about the NADPH oxidase complex, nicotinamide, dinucleotide phosphate oxidase complex, that the whole purpose of that enzymatic complex is to produce reactive oxygen species of ROS. So how does it work? So now let me drive you to high school and let's talk about basic chemistry. So the whole idea of the NADPH oxide complex is to remove 2 electrons from NADPH and transfer them to oxygen. So that, do you agree? Do you agree? Tell me yes. I guess that he does. He's very focused. Let me tell you, pay attention because then I'm going to ask you questions about it. Oh, yeah. And then you may get a milkshake that mom is going to get to you. Oh, yeah. So reactive oxygen species, so we produce 2 electrons and we donate them to oxygen. And the whole idea is to produce superoxide anion. I know I'm going to make fancy names, but bear there with me and you will see why it makes sense. So here we have superoxide, but superoxide as a reactive oxygen species is not very stable, it's not very good. So then through different mechanisms, especially enzymatic enzymes like superoxide dismutase, we produce hydrogen peroxide. And then through another enzymatic process, we produce hypochlorous acid. Why is this important? Because they have commercial value. So here you have hydrogen peroxide, the one that you can get at Walmart or whatever where you buy your stuff, and here you have bleach. So hydrogen peroxide is here, hydrogen peroxide, and the base for bleach is hypochlorous acid. So the same product that we use in our kitchen or to clean our utensils is the one that we use in our phagocytes. When we engulf microbes, we produce hydrogen peroxide, we produce bleach, and we kill the microorganism. So the same thing that we do in biology, we do in our kitchen and with our furniture and our utensils. So what about CGD manifestations? So unfortunately, CGD is not one disease. It's 2 diseases in terms of clinical manifestations. So patients with CGD, and you know better than I, you are highly susceptible to infections. Not all infections, we'll discuss that, and immune dysregulation. You have a combination. You usually have a lot of infections because the immune system cannot fight the outside, and then you have immune dysregulation where the immune system fighting the inside. So it's a bad combo. So you cannot fight microbes and then you start attacking yourself. Not a good combination to have. So what about the infectious disease susceptibility? So this is semi-easy to understand. As I told you before, we have the NADPH oxidase. We produce superoxide, hydrogen peroxide, hypochlorous acid, and those help us to fight fungi and bacteria. So we engulf those microorganisms, we produce hydrogen peroxide and bleach, and we kill them inside our cells. So then, that's easy to understand that you have infectious susceptibility. Why bacteria and fungi? Because usually we don't have any redundancy to fight those microbes. So for viruses, we have B cells, we have immunoglobulins, we have T cells. For these microbes, we need hydrogen peroxide and we need a hypochlorous acid to fight them. So if we don't have them, we have a hole in our wall, so where those microbes come in and we cannot kill them. So that's why patients with CGD are susceptible to infectious diseases, but not every infectious. So there's a particular set, and the rule is 5 by 5. And here you have them. So there are 5 major microorganisms and 5 major sites that are going to be affected whenever you have CGD. So the microbes are Staph aureus, Serratia, usually marcescens, Nocardia, Burkholderia, and Aspergillus. So those are the microbes that usually make up to 80% of the infections that CGD patients have. It's not that we want them to have them, but we know that they're the ones that we see more frequently. And which are the areas, which are the organs that they're affected? So you have the lungs, you have the skin and the soft tissue, you have the liver, you have the lymph nodes, and the bone. So again, 5 by 5. 5 type of microbes, 5 type of sites that they're infected, and you can see that Staph is very common in the skin, but not that common in the lung. Aspergillus, very common in the lung, but not that common in the skin. So it's this combination of microbes and sites that are the ones that give the infectious susceptibility that CGD patients have. So now a more complex and full of question marks. Why do patients have immune dysregulation? And again, this is an added benefit that CGD patients have. They have the infectious susceptibility and this immune dysregulation that drive to granuloma formation. Let's start about what we do know. So those patients have defective ROS, reactive oxygen species generation, and this increase the production of some cytokines that they're the hormones of the immune system that they tend to recruit different cells. So those patients cannot block the production of these particular cytokine, and this is kind of a very schematic and very simple approach, and this is not well known, so that's why it's full of question marks. But we do know that those patients have more of these inflammatory cytokines, that they increase the recruitment of inflammatory cells, mostly neutrophils and phagocytes. So you have more cells there, and then they don't die because they don't produce the ROS, that is the way of killing themselves after they kill a microorganism. So those cells keep the microbes inside, they don't kill the microbes. Oh, you don't need to clap. No, not yet. So let's wait for a little bit more. So they don't produce the reactive oxygen species, they don't kill the microbes, and then they don't die themselves. So they stay there. And they stay there, and they say they're sensing that they have microbes inside, and they keep on producing cytokines that they're pro-inflammatory, but they produce less of the one that they're anti-inflammatory. And this is a vicious circle, not a virtuous circle, that end up in increased granuloma formation. And this is kind of the thing that happens, the immune dysregulation. But again, not every site is affected, but we know that CGD, they have this bad combo of increased infectious susceptibility and autoinflammation and increased granuloma formation. Which are the sites that they are affected, or the areas of the organs that they are affected? The respiratory tract, depending on the type of CGD that we're going to discuss later, they will be affected between 13 and 23%, and the GI tract. Up to 1/3 or even more of CGD patients, they will have problems in their GI, gastrointestinal tract, that they are not infectious disease driven. It's because of this dysregulated immune system that they will have those manifestations. Others, connective tissue, kind of the underneath the skin, so the skin by itself, the blood types, the liver, the eye, the neuromuscular, and the urinary. I would say that the big three are respiratory, the lungs, GI tract from the mouth to the anus, anywhere there, urinary tract, depending the genetic type of CGD, so they will be affected. So again, bad combo, infectious disease susceptibility, immune dysregulation. But we were talking about CGD, and I was insisting on this is a genetic disease. So going back to high school, so let's go genetics 101. So all CGDs are genetic diseases, and here we have we have the DNA, where we have accumulated all the genetic information that it provides the template in order to produce proteins, are the ones that they are, for example, the ones that they make the NADPH oxidase system. So you have damage at the DNA, it's transmitted to the RNA, and then it's translated to a protein. So you have or no proteins or proteins that they don't work properly. So everything because your DNA has a damage or a mutation, how we call it. So CGD, again, is not one disease. It has genetic heterogeneity. Genetic heterogeneity. We have one disease, CGD, and we have 6 different genes that they're completely unrelated, except that they're part of this complex that is the NADPH oxidase. CYBB, CYBA, and CF1, 2, 4, and CYBC, or EROS, very erotic name, but it's essential for reactive oxygen species generation. So all of them are the genes that are associated with CGD. 6 genes, 1 disease. We used to believe that it was 1 gene, 1 protein, 1 disease. We know that that's not true anymore. Now we can go in both directions. Multiple genes giving a single disease, or a single disease like CVID being produced by multiple genes. So it goes in both ways. So here you have the gene, here you have the number of the protein, GP, glycoprotein, 91 is the molecular weight, FOX is phosphatase oxidase, so this is how the nomenclature is made. GP, glycoprotein, P is protein, the number is the molecular weight of each of them. So this is how we name the genes and the proteins that are associated with CGD. So here the frequency, depending on the area of the world that you live, the frequency of which are the genes that are responsible for CGD. Western countries, CYBB is responsible for 65% approx, 2/3 of the case of CGD. If you go to areas where consanguinity is high, the other ones are more frequent than this one. So this stands truth in the Western world. In countries where consanguinity is high, like the Middle East, so the numbers are completely disrupted. Nothing good about it, but you have to think about them. If you see a patient with CGD and you're like gambling, you say, oh, you're probably going to be a CYBB because you're in the Western world. But if you are in the Middle East, you said, no, it's very unlikely they will have CYBB because there, because of consanguinity, all the others are the ones that are more prevalent. And these drive us to the inheritance form. So there are two inheritance forms for CGD. One is called X-linked, the others are autosomal recessive. So let's go into genetics. So here, again, genetics 101, we have 23 pairs of chromosomes. We have the sexual chromosomes, the X and the Y, and we have the autosomes that they're 1 to 22. So CGD that is produced by mutations in the autosomes are called autosomal recessive. The ones that they are mutations in the X chromosome, it's called the X-linked recessive. So males, we are made by one X and one Y, females, 2 X chromosomes. So now let me focus on the X-linked recessive form of CGD. So areas that we know and we discussed yesterday night, and people were telling me about their experience, so they knew everything about that. But for those of you that perhaps that not that versed in the genetics, so let me go over here. X-linked recessive is the most common form of CGD in the Western world, and usually you need just one mutation. And the most common situation, you have a mom that is a carrier. That's actually 2/3 of the times. 1/3 of the times mutations are de novo. They happen in the affected individual. But the most common scenario is that you have one mutated allele here in blue, and the mother going to be called a carrier. Carrier, they are usually asymptomatic. That's not completely true, unfortunately, for CGD. Carriers, they might have manifestations. So, but how it works? So we are made by half. So then the progeny of these individuals, here you have the male that is unaffected, doesn't carry the mutation, the mom that is a carrier. So how the genetic information is passed to the next generation? So it's going to be passed by half. So mom, so the mutated information can pass to a boy. So a boy, because it has just one X chromosome, is going to be mutated, the boy is going to be affected. So if the mom, the genetic information, the mutated information passed to a girl, and who decides the sex of the project is going to be the dad. If he provides an X, going to be a female. If provides a Y, going to be a male. So that if we have mutated information passed from the mom, and here we have an X chromosome for the dad, he's going to be a carrier just as the mother. On the other hand, if the mom is passing the non-mutated allele to a female, it's going to be obviously a healthy female, wild-type female, and then it's going to be a wild-type boy if the dad passes the Y chromosome. So here you can see with the X-linked pattern, you need just one mutation that is usually comes from the maternal side, and you can have an affected boy or a healthy boy, you can have a healthy girl, or you can have a carrier female just as the mom. There's another aspect that is interesting in terms of the genetics. It's called the X chromosome inactivation. So females, as I told you, they have 2 X chromosomes, but this is too much. They cannot handle them. So it's too much femalinity there. So they say, no, I cannot have 2. I can have 2, but I have to inactivate one or the other one. So, and this is random. It's called ionization. It happens very early during embryogenesis. It happens randomly. It happens for the whole chromosome X, and it happens for the whole progeny. So moms can inactivate the paternal X chromosome or the maternal X chromosome. The problem is, if they have a mutation that one of them is mutated, and if they inactivate the wild type and they maintain active the mutated one, they will have the disease. So they have 2 X chromosomes, but just one of them going to work. So, but they inactivate all of the wild type and they maintain active the mutated, they're going to behave as CGD patients. So that's another aspect of how come this disease can be manifested. So then we go to the autosomal recessive form of the disease. This is more classical, and this is easier to understand. So here you need 2 mutations, and one from one parent and the other one from another one. So here we are looking for the blue one that is the mutated one. You see the dad so carries one mutation, the mom carries one mutation, and the chances in our pregnancy is 25% chances to have an affected are going to be a boy. So here you have mutated, mutated, and here you have that you can pass the disease here. So a carrier, you can have a female carrier, or here you can have a female, a boy carrier, and you can have a female that is, or an individual that is completely healthy. So in every pregnancy with autosomal recessive diseases, you can have 25% chances to have an affected individual, 50% chances of having carriers, and 25% chances of having 100% healthy individuals. So two inheritance models, two different ways of pass the disease from one generation to the other one. What about the diagnosis? So back in the 60s, so people came up with a way of diagnosing this disease, and that was genius. So the idea here is you have here neutrophils, you incubate them with a dye that has no color. So here we're using MBT or nitrogen root tetrasodium, and we incubate the phagocytes with those cells that they're going to be passively loaded with the dye. Then we stimulate the cells, and this dye that have no color becomes colorful. In this case, called formosant. So the beauty of this is can distinguish the cell that they can produce ROS, and they can change the color from the colorless dye to the formosant that it has a color. So the bad side of this is very subjective. So you have to count 30, 100, 200 cells, and they're very observer dependent. And the thing is, oh, is this a positive or this is a negative? So there's a lot of subjectivity in terms of these tests. But it was fantastic. In the 60s, it changed the way how we diagnose and saw this disease. So here, imagine, it's very observer dependent, and you can count 100, 200 cells. Back in the 90s, there was a revolution in terms of the diagnosis. That is the DHR, 1,2,3 dihydrorhodamine test, and the principle is exactly the same. So now we're using a dye that has no color, 1,2,3 dihydrorhodamine, and then we're stimulating the cells, it becomes colorful, but now we're not using our eyes. We're using flow cytometry to measure the activity. So now, instead of having an individual say, oh, this is positive, this is negative, no, we have a machine that uses a laser in order to determine how many cells are positive. And not just how many cells are positive, we can check the intensity of the positiveness. So here you can see a healthy control. Here are the cells that were loaded with a dye, they were stimulated, and they move from here to here. This is a logarithmic scale. So this is kind of 1, 2, 3, like 100 times, 1,000 times more dye that have changed in color. You can see this one here, and you can see a patient, insulin CGD, that it didn't move at all. So clearly this patient couldn't make any reactive oxygen species, so the amount of colorless could not be moved to the colorful kind of dye. But what I was telling you, this method is so sensitive and objective that it can also tell us, okay, here you have a patient that doesn't produce ROS at all, but here you have another one that produces some. And this is the case on the patient that have milder mutations, that they can produce some, and this usually is related with better clinical outcomes. So if you produce nothing, not very good. If you produce some, you might be okay to fight some infections rather than some others. And here is the crazy thing about females. Sorry, I had to say it. So here's the X chromosome inactivation. I told you that females have 2 X chromosomes, but they cannot handle them. So it's too much femininity there. So then you have the 2 populations. Here's the one that inactivated the mutated, so they're working perfectly fine. This one is the one that inactivated the wild type, and they're not working at all. Usually, it's a 50-50% thing. We like to believe it because 50-50 because it makes some sense, but usually it's between 20 and 80. So when you fall below 20% of the good peak, you might be in trouble. But females, that they are carriers, so regardless of how much the X chromosome inactivation numbers are, the immune dysregulation is intrinsic to the female carriers. So we call them carriers in terms of infectious susceptibility, but in terms of immune dysregulation is intrinsically associated to carrying the mutation. If you're a carrier, even you have 90% of your cells that they undergo positive reactive functional species generation, the autoimmunity immune dysregulation is intrinsically associated to you. You might not have infections, but you might have immune dysregulation. So then the next revolution in terms of CGD happened, that was the molecular diagnosis. So before we were very happy with the clinical manifestations. From there, so that was in 54, then we moved to 65, where we moved to the MBT test. Now we want to know which are the genes, because depending on the genes that they're affected, and also the type of mutation, the outcome that you can predict, and even if what's going to happen to you with bone marrow transplant. So before, we were doing Sanger sequencing, that looking for particular mutations in particular genes. Now, probably some of you that they're diagnosed in the last few years, so probably have been diagnosed by next generation sequencing panels, where we take 500 genes, 20,000 genes, the whole genome, and we analyze it in an unbiased way. It's okay, tell me where it's mutation. We analyze that and say, oh, here it is. You have a clinical phenotype. We don't go by one gene at a time now. Now, because we became rich and lazy at the same time, we want to do everything at the same time. So the panels, they usually have 500 genes. The whole exome has 22,000 genes. Here, the whole genome has the 22,000 genes, but all the 100 times more genetic information that can tell you what's going to happen in your genome all at the same time. So now you need the clinical manifestation, the test, the functional test, MBT, we don't use that anymore. The DHR, that is a fantastic test, and the genetic to close the circle and have everything related to your disease. So what about treatment? So I'm going to go very basic, so that doesn't cover the specifics of the disease. I'm going to go for prophylaxis, and I'm going to go for treatment of curative of the CGD. So in terms of prophylaxis, we do know that these patients have susceptibility to infections. And as I told you before, infections are usually bacterial or fungal. And that was in 72, the first trial that did show, yes, these patients are going to benefit if they use antibacterial prophylaxis. And that was fantastic for many years. And they decreased the number of bacterial infections, and then people said, oh, now they're getting fungal infections. It's not that they were getting fungal infections. They were getting them before, but because those were so much prevalent than this one, those ones were not that obvious. That drove to the next clinical trial to using antifungal prophylaxis. And now we were using antibacterial and antifungal, the different brands, the different times. You will discuss it with your doctors, but it's always going to be antibacterial and antifungal prophylaxis. And then 1991. So this is another landmark in terms of the primary immunodeficiency studies, because this is the first randomized placebo-controlled double-blind study that has been applied to a primary immunodeficiency. In 1991, they were testing interferon gamma as an immune stimulant. So they have patients that they were blindly treated, so neither the patient nor the doctors were knowing if they were getting the drug or placebo, and then they cross over. They said, okay, you got product A, then you got product B, and what they show is that immune stimulation worked in terms of preventing infections, giving more time free of infections, and prolonging the life of those patients. So it works. It's not as popular as antibacterial and fungal infection because it's expensive, because it's painful, it gives you fever, but it works, and it's the first double-blind placebo-controlled randomized trial in the field of primary immunodeficiency, and it does work. What about curative? So we know that we can prevent infections. I'm not going to discuss the specifics of immune dysregulation, but you know that steroids are kind of, again, a cornerstone of the treatment of immune dysregulation. But what when you want to cure the disease, just to completely cure it? And that's kind of bone marrow transplant. This is 2001, so that was started at the NIH. There were just 10 patients, but it was a proven thing that the HACT or bone marrow transplant worked. There were experiences before. The first patient was transplanted in 77. Here you have the first series of 10 patients. Now, the papers that they describe bone marrow transplant in CGD, they have 700 patients. So now it's a kind of established therapy, and it works. So patients are cured 85%, they have no manifestations, 75% of them, it works. What is up and coming is going to be gene therapy and gene editing. That was extremely good at that time. The outcome at the end was not good because, depending if you went to the talk by Don Kahn before, so we deliver the genes and they go sometimes to places that we don't want them to go. And that could be associated with malignancies and other complications. So this is already established, this is up and coming. But those are curative options, so bone marrow transplant, gene therapy, and gene editing. So let me recap what we have discussed. So we discussed about CGD history. Now we have the 70th anniversary. Everything from CGD 71 years ago didn't exist. Everything we know, it had happened in the last 70 years. So pathophysiology, hydrogen peroxide and bleach, we can produce it. We cannot kill bacteria and fungi. That's what gives patients with CGD increased susceptibility to infections. Manifestations, infectious diseases, immune dysregulation, not a good combo. Nobody you choose to have this disease, but this is what, what happens when you have mutations in the NADPH oxidase system. Genetics, two forms of inheritance, X-linked recessive, autosomal recessive. This one, you need one mutation in one gene that's called CYBB. This one, the other 5 genes that are associated with this disease. So you need 2 mutations there, usually one from dad, one from mom. Nobody is guilty. So we don't choose which genes we pass to our progeny. So this is just random happening, and we have to deal with that. Then diagnosis, we discussed about MBT, great idea. Now we go with something that instead of looking to 100 cells, 10,000 cells, flow cytometry, not just help us to diagnose healthy individuals, patients, it tells us the amount of reactive autoimmune species that they produce, that we can predict how good or bad the disease can be. It's not a 100% linear correlation, but you know that this guy might not do as good as these guys, and here it can help us to distinguish the lionization level of females, that they're extremely lionized, they inactivate the good one and only have the bad one, they can behave as CGD patients. Treatment, remember, prophylaxis, bacterial prophylaxis, fungal prophylaxis, and immune stimulation, not that popular in the whole world, but so bacterial and fungal, it works. This one has its pros and cons, and many centers use them a lot, some other centers don't use them a lot. Treatment curative, bone marrow transplant, established, well done, well recognized series of 700 patients is the gold standard at this point for cure. Gene therapy up and coming. We have to keep our fingers crossed because they're going to keep on improving and going to get there to you guys at some point. And that was all what I had to do for you and to tell you. Thank you very much for your attention.